Welcome, everybody, to Recovery Machine. My name's Nathan, and I'm joined, as always, by your good friend, Corey. How are you doing, Corey?
Hello, sir. I'm doing well. Thanks. How are you doing?
Not bad, not bad. Saying I got a little bit of a shoulder injury going on, so if I look like anyone who's watching the video, I look like I'm, got a broomstick. It's because I can't move my neck very well, so don't be alarmed. I am, in fact, a human. Yeah. So what we wanted to do today is take a look at one of the diagnostic tools that physicians use for diagnosing substance use disorder. So in the DSM-5, which is, what is it? What's the actual thing? Diagnostics and Statistical Manual of Mental Disorders.
That's right. Yeah.
Big mouthful there. This is what they use when they're diagnosing people. Usually, if you're, in our case, when we went into our kind of interviews to be assessed, our IMEs, this is the criteria that the physician would use. So there's 11 different points on there, and we'll go over kind of how the answers to those questions break down and how that diagnostic tool is used. Then we're going to go through each point, each of the 11 points, and we're going to talk about ways that we think maybe they can be improved, or areas that that might not serve the patient as well as they should. And then after that, we're going to attempt to put together a list of questions that would perhaps be a little more accurate and hopefully better. That's we would try to improve. I know. What do we know? What are we doing? Trying to improve on such a document, but we're going to try it anyway.
Yeah.
And you can make of it what you will, but I believe there is improvements that can be made there. So what do you think, Corey? A worthwhile enterprise?
Definitely. And I think one of the things we highlighted before starting up here today, we want to highlight any moments along the way where it seems to be sort of influenced by stigma, influenced by societal positions, or if the language needs to be changed, or if it's just flat out wrong.
Right.
And hopefully we'll come up with a better way.
Yeah, because like anything else that you're using as a diagnostic tool, if you're a physician, it should be patient-centered, and you want it to be calibrated in such a way so that it's giving you information that's useful and somewhat discerning. You don't want something that's just going to be a giant net that's going to catch anybody. So we'll go through this and we'll see. So with 11 points, the first thing I'll state here is that the first point they make before getting on to the 11 different questions they ask is that they're looking for what they call a problematic pattern of use leading to clinically significant impairment or distress as manifested by at least two of the following occurring within a 12-month period. So if you answer yes to two of these 11 questions at some point in the last year, you automatically qualify for a mild substance use disorder. So what I would like people to do who are listening is, as we go through this, I want you to think about your answer to the question, whether it's going to be yes or no. And this is going to be within the last 12 months. And we'll see how far you can get before you get diagnosed. And then to what degree you get diagnosed as well. We can look at the end.
2 out of 11 is 18%.
Yes.
18% of the 18% correct answers, or 18% yeses. That doesn't seem like a whole heck of a lot.
It doesn't. And there's ramifications for certain subsets of our population that we can talk about as well. But we'll start by asking the first question here, Corey. So to qualify, the first one is taking the substance in larger amounts or for longer than you're meant to, or I guess it would be if you used alcohol for an example, maybe you're going to go out just for one beer, and somebody talked you into having another beer.
Yeah,
that kind of thing. But that could be, this is mostly stimulants, and I think most of your standard 12 panel drugs are in this criteria. So
yeah.
what do you think about that?
I think it's really interesting. I think just going back a moment to what you said about, asking people to look at themselves, and this is, we're ideally setting something up for self-assessment here, that you can look at this on your own and be really, really honest with yourself. But yeah, like you said, Nathan, like if you went out for dinner with friends and no one wanted the night to end and you ordered another additional bottle of wine, you would then potentially, and that happened, maybe these were friends that you saw every couple of weeks and that was consistently happening, you would then meet the criteria right off the bat there.
Well, if you had an extra glass of wine at Christmas and you only intended to have one glass of wine, you would technically qualify, right?
Yeah.
The last 12 months.
Yeah. Or if you had a injury, or you were recovering from surgery or some sort of physical injury, and your requirements for pain control went on longer.
That's right. Or if you're a chronic pain patient and you have say you take 100 milligrams of hydromorph a day, that's your prescribed dose, but the doctor's given you a breakthrough prescription for times when your pain is uncontrolled in that with the sustained release medication. So if you took, you were trying to just most people tried to just keep to the sustained release and get by with that. But, gosh darn it, you had a couple days in a row there where that pain was uncontrolled and you ended up using that extra 10 milligram, whatever, for breakthrough. I think you would qualify.
Yeah.
Right. How could you otherwise plan to, the other thing that's a little strange is, if you're a recreational drug user, there is some planning that goes into that, mostly around navigating the law and safety and the problems that we have in those areas. But outside of that, not a lot, what you can handle to some degree, but not everybody goes out, you're going to go over and smoke a couple of joints with your buddy. You don't, decide before you go how many puffs on a joint you're going to take, right?
No, certainly not. Or even how many, you might say, I'm going to limit myself to 1 or 2 glasses of wine. You might say I'm driving, and then that is a factor that limits you. But if those sort of pieces of structure don't exist that would act as like like the driving thing, it's like it's easy to make that a reasonable cause for not letting that go.
Yeah.
But if those pieces aren't in place, then it can sort of, away you go.
Yeah. And everybody, that kind of, not to read too much into it, but it kind of seems like it makes it seem like managed recreational use is not an existing thing in the world.
Yeah, it does, doesn't it?
Yeah. So that's the first one. Second one, we move on to wanting to cut down or stop using the substance, but having trouble doing so. So what are your thoughts on this one?
Yeah, it makes me think of like the people who say, well, with any substance, but smoking comes to mind, alcohol comes to mind again, where we've heard people say, "Oh, I've got to cut back. I've got to watch my intake." And maybe the thought ends there. Life factors continue, both good and bad, and there could be 100 reasons for it, by using their language, that make you unsuccessful. Unsuccessful is the word that they use here.
That's correct. Yeah. One thing that's interesting about this is it is a point of where I look at my opioid use in the past. I had tried many times to cut that back, and I tried to quit, but I was somewhat successful at managing my dose, but was unable to lower my dose on my own. So for me, that for my drug choice under those circumstances, that would have been a question that was relevant.
Yeah.
But I've done the same thing over my life with alcohol. And I don't consider, when I was younger, I drank much more, and no question, it's not good for my health. I don't think that any alcohol is good for your health, but there's other kind of lifestyle risks and associated malfunctions that come with drinking. And you accept that as a younger person, maybe because you're less risk averse. But like this year, I mean, I could. There's nothing stopping me from drinking, but I haven't had a drink yet this year, and I don't care really. You know, so those two things within the last 12 months. If you go back to when I was in trouble, there would be a difference there, but I don't think the alcohol would still be in the same category, you know? So it's, what I'm trying to say is that there is a difference between drugs, even in a per question sense.
Yeah. You know, I was just thinking about myself, and I've talked about this on the podcast, that I would tell myself daily, weekly, that I wasn't going to go back to work and take any hydromorphone again. But was there an effort there? Did I change my environment? No. Did I reach out for any help? No. Was I doing any therapy or counseling or anything like supportive, anything to change my potential future behavior or current behavior, apart from saying to myself, I'm not going to do it? No. So was there effort on my part? I can't honestly say that I had put forth a big effort to change. You know, I think I was aware that I had a loss of control, that telling myself I'm not going to do it was not enough, but I hadn't made larger efforts to try to mitigate that behavior.
Yeah, that's a great point. And I think this is what separates people who are wanting to stop smoking from people who actually stop smoking. It's putting a system in place, because for many years, for people, they know they want to stop smoking for all sorts of different reasons, but they still enjoy it a little bit, or they don't want to put the effort into putting a system in place, because they know if they put the system in place, then that's when the real work starts, right? So there is kind of a difference between, maybe tomorrow I won't use as much or whatever. It's one thing to say that. It's another to actually make a plan. Okay, well, how are you going to do that? Because we've been using this amount every day for the last, 2 weeks or whatever. So what's your plan? Without a plan, it's just words, Yeah. So totally. That's a great point. Spending a lot of time. This is number 3, spending a lot of time getting, using, or recovering from use of the substance. So this could be alcohol. Interestingly, they don't include nicotine in this. It's like nicotine gets a pass and all this stuff.
Yeah.
But, it could be alcohol, cocaine, opioids, inhalants, anything, well, of course, really.
And legalization and decriminalization impacts the amount of time and effort that is required to get said substances.
Of course.
So, if someone is using marijuana 5 times a day, well, it doesn't take a whole lot of effort anymore. You can drive within 5 minutes in most communities in our province now and obtain it. Other substances that have not been decriminalized, it's much, much more effort, much more time, much more risk.
Yeah,
much more lying and deceit, or planning and things like that, for sure.
Yeah, that's why when I hear people talk about how people with drug problems are liars and stuff like that, it makes me think, well, they can't. This society has created a state where you can't be honest. I mean, if we were grown-ups and we were honest about our drug use, and drugs were part of our culture legally, we didn't have to worry about going to jail if we were going to go out and, I mean, it used to be like that just a few years ago. You get caught with a bunch of cannabis. I mean, you think how crazy it is and how long it took us to get to that. Now we got other substances out there where you get caught with enough, you could actually go to jail. It's a wild thing. So to say spending a lot of time, well, what are you supposed to do? I mean, I mean, if you don't spend the time being cautious about procuring drugs, if your drug of choice is not legal, you don't have a lot of autonomy there. You don't
Right.
have the personal freedom to just do your drug of choice without possibly severe repercussions that have nothing to do with your medical state. You
Yeah,
know?
exactly.
So
The other phrasing I kind of take some issue with is the point about the recovering from the effects of the substance. If you are someone who is quote unquote high functioning, or I think about professionals like ourselves, like you do keep going, and I don't think recovering from the effects is necessarily a measure, or
no,
at least I wonder. I
it
think
would be
maybe.
actually the opposite. Like without if you took the
Mm,
substance away, when I was using opioids to work, if somebody would have taken it away, I mean, obviously I would have withdraw right away and be useless. But if it would have been not part of the equation, that I would not have been able to function. There would have been more recovery time, and I would have been able to work less. You
yeah,
know what I mean? So
and the same goes for alcohol. Even alcohol, very much it's the other side of that for sure. It's
it
the
can
absence
be.
of alcohol. Yeah,
Yeah, yeah, yeah. I mean, I think this one might be pointed at alcohol because it's kind of like, oh, okay, this person is they're drinking so much they can't make it to work, or they're drinking so much that they're
yeah,
passed out, not taking care of their family, and that is a problem. There's no question about it. But
yeah.
um, that's a substance specific problem. So for 4, they've got cravings and urges to use the substance. So if you've craved a substance, whatever your preferred substance or any substance, I guess, in the last 12 months,
Oh
then
yeah.
I don't know.
This one is bonkers to me. How many people have you heard in passing or casually say, "Oh, I can't wait to have a glass of wine tonight"? People at work, we've talked about nurses or healthcare workers getting, nabbed or called in because they said, "Oh, I'm going to go home and have 2 glasses of wine tonight." I tell you,
Yeah. Yeah.
DSM check.
Yeah. It is, first of all, that's something that goes on in your mind.
Yeah,
So, and we need to be mindful about how this diagnostic tool is being used, because many times, unfortunately, this tool is being used to take somebody's autonomy away
correct.
or categorize them in such a way that makes the rest of their life forward or past that categorization different in a negative way.
Yeah, yeah.
So this is it's almost thought policing. You know,
That an urge is inherently bad, and
and
I think that is so ingrained, and I think of recovery meetings that I've attended where such a common thing I've observed is that an urge or a craving is accompanied by shame, and
mm,
that people feel like a failure for an urge and a craving, when an urge and a craving is such a human experience.
right, you be aware of it, you see it
Yeah,
for what it is, you know that if you let it pass, it will most likely go away. And, most cravings, I think they've done studies on them, and they're about 45 minutes to 2 hours, depending on your state of recovery. But
yeah,
for a person who's in a generally, like a not somebody who's, but to take somebody off the street, I guess, and ask them how many times they crave a drug in a day, and it's going to start with, well, maybe the coffee in the morning would be the first thing, and then by the end of the day they're thinking about a beer after work, and then maybe they smoke. And I mean it's and that's just the drugs. We're not talking about other addictive behavior too, right?
yeah, yeah. I mean, the coffee thing is such an obvious, but it bears some conversation. Like, I, for one, the trip from bed to coffee maker is magnetic and mindless. It is so it is so driven by an urge
Mm-hmm.
that it is. I could just do it with my eyes closed and one hand tied behind my back. And like,
Right.
if my hands were tied behind my back, I would figure out a way of doing it with my toes.
This is
Like,
classic compulsive behavior. I mean, if we scanned your brain, you would see a very developed superhighway of neuronal activity where everything's been pruned around it and it's just developed into this just strand that's dedicated to getting you from waking up to having coffee in you.
Yeah.
And yeah, that's one of the ways that humans evolved, and it serves a purpose. And we've talked about it before, but yeah, I don't know. I don't know how I don't know how you're supposed to answer that one honestly without saying yes. And
yeah, that's exactly, Nathan. That's sort of the point for sure.
Is there anybody out there? Please, I would love to hear from somebody. Maybe you're a Buddhist. Maybe you're somebody who's found a tranquil state that I would like to learn more about. But if there's anybody out there who hasn't had a craving for some sort of a mind-altering substance in the last 12 months, please contact me and let me know. I want to learn from you.
Yeah. You know? And this is where like the going back to stigma and to judgment, like the coffee thing, my admission of that trip from bed to coffee maker is so similar in terms of, like you said, in terms of neuronal pruning and the development of that pattern of behavior, that but then we look at someone who's addicted to alcohol, and so many alcoholics would describe, driving down the street and they're not going to go into the liquor store, and then suddenly their steering wheel makes a left and in they are, and in they go. And it's the same thing.
Yeah.
It's the same thing.
Exactly the same thing.
And yeah, I mean, is my cup of coffee affecting, I can't think of negative implications of my cup of coffee in the morning. I think someone who's addicted to alcohol could probably much more easily draw a line to some negative implications of their alcohol use, but that pattern of behavior that gets you there is the same.
Exactly the same. Yeah.
Yeah.
So moving on, I think we've already diagnosed ourselves with substance use disorder. Number 5, not managing to do what you should at work, home, or school because of substance use.
Yeah.
So is the substance, whatever your substance, polysubstance or substance drug of choice, is it causing you problems elsewhere in your life? And this is a more legitimate question, in my opinion. What do you think?
It is. It's a really interesting question. Again, it makes me think about those of us who are high functioning in their addictive behaviors, that the impact on my work. Now, I was violating practice standards and a code of ethics, but otherwise, it wasn't affecting my performance, at least by virtue of the fact that I wasn't receiving negative complaints or concerned colleagues coming forward to talk to me, or errors that were coming up, things like that. I can now be more honest and say that it affected how I felt at work. It affected the behavior that I was doing around getting the substances. But in terms of feedback, that wasn't there at all from anywhere in my life.
Right. There is another angle on this one, and it's that it is a little bit invasive. It's a question that it bears asking for sure, but everybody's going to have their own standards for what their level of commitment to each of these things is. If you're committed to, maybe you hate your job, you don't care about your job at all. In fact, if you get fired, you'd be happy about it. So whether your substance, is making you late to that job or whatever, you don't, you've already factored that out. So for you, that wouldn't be a big deal. Conversely, if you're a scientist working on something akin to the Manhattan Project and you can't string two thoughts together because you've been out partying the night before, that is something that needs to be addressed in a different way. So the point is that each one of these components, whether it's managing what you're supposed to be doing at work, home, or school, that's about you and what those things mean to you, not what society thinks you should be doing at work, school, or home. That's none of their goddamn business. You know what I mean?
Yeah. Yeah.
So the question comes off in the way it's stated. I've got kind of a nicer formulation of it here that I'm using, but in the DSM-5, it's stated as more of a, like, are you taking care of the things you need to be taken care of, sir?
Mm-hmm.
You know, that kind of and it's like, well, if I am, that's my business. And if I think that I have a problem with taking care of those things, then we don't really need to do this test, do we? Because I'm already telling you I have a problem.
Yeah.
So it's, it's interesting.
You know, it makes me think of the use of stimulants for studying, but university students who use stimulants to get through their midterms and finals and keep up to study. I also knew one of the best physicians I ever worked with was quite open about his use of prescription stimulants, and made no bones about it. Didn't say he never said I'm misusing them or taking them beyond what the prescription is for, but he was very open about that. And
yeah.
And did it affect his job? He was incredible at his job.
That's right. Yeah.
And that's neither here nor there, but like going back to the DSM question, like, is it affecting your performance or your ability to function at work? Well, it made him better than the physicians he worked with, probably.
Probably. Yeah. Work longer, work harder. Yeah. Many physicians have prescriptions for stimulants, and I don't think they all have ADHD.
No.
So yeah, that's it's an important question. If I guess the strange thing about this is when I was presented with it, it was it seemed like a surprise attack. And if I didn't know what was going to happen if I answered honestly. I trusted the doctor, and I was like, well, geez, I ended up answering yes to a lot of questions on here, but I didn't understand the ramifications of answering yes. And I've even seen people answer. I think I've showed you several IME reports where they've had patients who have scored very low on these, about as low as a human being can score, and they still get sent away, or even marked severe when they've only got like a couple things marked off. It's I got the feeling that it wouldn't have mattered what I said once this thing came out.
Yeah.
I could have lied my ass off and not had a single thing on there. And it was, well, you know what? I still feel like you should go. Like, so what are we doing this thing for?
Yeah.
Like, what kind of a tool is this? But anyway, next one, number 6, continuing to use even when it causes problems in relationships.
This is another interesting one. This is one that you and I were talking about in planning this episode, and about stigma, about how stigma can come into this. But to me, when I think I've been thinking about that for the last couple of days, and so 2 things. I think it requires a really high level of honesty, even just in not necessarily even in conversations with other people in your life, but just conversations with yourself about, is it impacting relationships?
Right.
Do I do things that are either deceitful or dishonest, or that allow me to maneuver around people, or maneuver my substance use around people?
Yeah. And then we have to ask, as a society and a culture, why? Why do we feel the need to do that, even when we know it's contributing to death?
Yeah.
How many times have we seen a spouse hiding their drug habit because they were worried about what their spouse would think about them? Whereas if we didn't have that level of stigma, and we're able to discuss these things, hopefully way earlier on in your relationship, before you're married even. I mean, the number of people I see, I have friends, and they've married people that don't know that they do drugs recreationally. And that's always baffled me. I'm like, this person is very close to you. This is the person you've kind of picked as your main person, and you're gonna like not you're gonna sneak around behind their back. Like, I just don't understand. Like, I get why the other person, like, there's many myths, and the stigma around drugs is vastly blown out of proportion. But shouldn't that have been something discussed much earlier on? In this case, we're talking about romantic relationships, but it could be any relationship. And I think the closer you are to the person, the more it bears discussing. If you're hanging out with somebody and you've been good friends for a year, and all of a sudden they break out a bag of cocaine, and the other person's not into cocaine, that's going to be weird.
Yeah.
That doesn't usually happen because friends talk about stuff, right?
Yeah.
And it usually comes up early enough so that if for whatever reason a person's like, well, I don't really like hanging out with people who do cocaine, or they had a bad experience with cocaine or whatever, so they would move away from that person before they ever got closer. And it's like, there is definitely an accountability and an onus on the person using the drugs to monitor how it's affecting especially important relationships. And if those relationships are indeed important to you, then you're going to have to put that importance right up against the drug in a comparison sometimes, if that person is not comfortable with your drug use. Mm-hmm. And then, hopefully it's something that you do early on in a whatever kind of relationship. But if not, then, that requires some brutal honesty sometimes that many people are not prepared to do. I see so many people who, they've obviously got a love affair going on with whatever their drug of choice is, but they also love their wife and they don't want to get divorced, or they also love their husband and they don't want to get divorced. Like, well, this is a bad spot, so it can get real complicated real fast.
It also makes me think, though, about getting honest with myself about all of the interactions I had with family and friends before they knew anything of my substance use. And it would be very easy for me to say it didn't impact those relationships. They didn't know about it. But like, were there behaviors that I was exhibiting in and around substance use where my behavior was altered? I was more temperamental, or had a shorter fuse, or was more antisocial, or curt in my interactions, or with my coworkers, who were the ones who were seeing me in an intoxicated state. And I could have very easily said, like, I'm great. And I was. I was performing my job at an acceptable or better level. Mm-hmm. But were there moments that impacted those interactions? For sure there were. Absolutely. For sure there were. And and those can be really subtle. Like, where it's not even about necessarily overt things like deceit or like lying to your coworkers, but just about how you respond to them, or times where, particularly near the end before going off work, where I was more on edge, mm-hmm. and more irritable and things like that. And there is an impact on insight.
Oh,
for a variety of reasons.
Absolutely. There's an impact on insight. And I believe that it's difficult with some substances, opiates being one of them. To me, it makes it both easier to be empathetic towards the general population of humans, but harder to form real connections with the people I love. It's a double-edged sword that way. And it's to do with the numbness, that warm blanket. It makes it so that you feel like you're always okay. So it's like you don't need to, your parents call and you're like, do I need to talk to my parents? Whereas when you don't have that substance on board, I think, well, Jesus, it's my parents. Even if I'm busy, I should, try to communicate with them, because you want to connect with them, and they're high value people on your list of people that you care about. And, it should mean something to you, and you should try to connect with them. But I think it's easier with some drugs to keep that. It's part of self-isolation too, but to keep that kind of shield up. And then you think the opposite of that would be a drug like MDMA, which is the epitome of connectivity. I mean, if there's ever been a drug on the planet that makes you want to connect with human beings.
So, and it makes me, this is kind of maybe an unpopular statement, but do you think, Nathan, that the big pushback for autonomy, that loud voice for autonomy with substance use that we're seeing now in response to drug poisoning deaths, for example, and the need for decriminalization and for legalization, and there's a loud voice there about autonomy in their substance use no matter what. Is that always accompanied by insight? How does insight interact with that? How does insight interact with autonomy? That's an interesting.
We could do a couple episodes on that. It's very complex, and I think insight is at the crux of the whole autonomy problem, right? Because this is how you're looking down the barrel of a Section 5 with somebody, and this is why it's so hard for us, especially if you're a parent and you've got a kid that you're worried the kid is out of control. The kid's gonna, they're doing drugs, and the street is littered with shitty drugs. And you're thinking, my God, if I force this kid into treatment, or if I force this kid into a mental health institution, they'll never forgive me. This could be a wedge that destroys our relationship for the rest of the time.
Right.
But you're weighing that against their life because you're concerned with their level of experience and insight. And that's a real thing. Right. So there needs to be some level of, I think that's where drug limits, like what we do with alcohol, we don't sell alcohol to 15-year-olds. Generally, that's in North America, we kind of have a different take on that, but we don't think that it's the way to go. And I agree that, from my own experience at that age, I just didn't have the capacity. Maybe I could add a little bit of alcohol, but not, if you just give me all the alcohol, I'm just going to drink it all. And I have no experience or ability even to control myself enough to make very good decisions with it. So there has to be some kind of an age limit. And then, this is part of the glory of having regulated, if we ever had regulated substances, because you would have different potencies, you would have, some idea about education that could be given at the time of sale. And, just instead of treating it like something that we're not going to talk about and everybody does it anyway, it would be much more mature, pragmatic to go at it that way. But you're right. Insight is a huge factor in that debate.
And it's a tough one because I certainly am not and don't want to say to a whole population of people, do you have the insight? Because that sounds incredibly condescending and talk, downward talking. And I don't intend to do that, but I do often think like the conversation has to be more honest than that about like, is it really working for you? And that's the phrase that we've come back to so many times. Like, how is this behavior actually working for you?
Yeah.
And I just think it can't all be good. It's not all good.
It's not all good. But you're treading into some interesting water there, because
I am.
You could say the same thing about democracy, right?
Yeah. Sure.
There's a real case to be made that there's some people who just don't have the insight or capability or the wherewithal, intelligence, whatever you want to call it, to be a part of a democratic process that's going to get a group of people trending in the right direction.
Yeah.
Do we take that vote away from them? Well, we don't. Why? Because we place freedom on a higher pedestal, right?
Yeah.
And that the consequences of that are catastrophic at times. Catastrophic. We're not talking about a few deaths here or there. We're talking about genocides, things that have been done in the name of nationalism based on the results of, sometimes true, sometimes false democratic processes,
Yeah,
but all under the guise of everybody having the ability to make that choice, right?
that's right. Yeah.
So it's kind of, it's an interesting one.
We digress.
We digress before we get out of control. Turns into a 7-hour episode. Giving up important social, occupational, or recreational activities because of substance use. So this is kind of like asking the work question, but more towards recreation, I think.
Yeah.
So sort of, do you still have things that you're doing other than drugs, or are you just sitting in your basement doing drugs? And
yeah,
I mean, there's some validity there as far as I think it speaks to your level of focus on your drug of choice, and there should be some balance in your life. Like you can't use drugs to make your life better if everything else in your life is shitty.
Right.
Like you don't want to play that game. It doesn't work.
Yeah.
But
and it's sort of tabulating wins and losses.
That's right. Yeah.
Yeah.
But that doesn't mean that recreational drugs can't enhance experiences that are part of your regular recreation. So,
you go to any sports game and bear witness to that.
Yeah.
People's
have a beer
experience being enhanced by beer.
Yeah, or go to an awesome concert on ecstasy or cocaine or whatever. Yeah, it makes it more fun. There's no question about it. So, yeah, that I think that's it. There's some validity to that for sure. A lot of things are covered in that question: social, occupational, recreational. That's a lot of things that could have happened in a year. But anyway, the next one is number 8: using substances again and again, even when it puts you in danger. So, I mean, this could be interpreted as using substances even when you're aware of them being like there's a negative or a result that you're not happy about, but you're accepting and you're using the substance anyway. What are your thoughts there?
Off the top of my head, like going back to the conversation we've had in the past about short-term versus long-term risks. This past year, new information came out about the correlation between alcohol use and cancer. So now that everyone knows that, for the vast majority of the population who were unfazed by that information, or mostly unfazed by that information, does that mean that they earned another check mark on the DSM checklist? I guess it does.
I guess it does. Yeah. I don't know of any. I mean, some drugs are safer than others. Alcohol is probably, in my opinion, and I think the stats would back me up, it's the most dangerous. It's the most deadly. It does the most damage to your tissues. It's hardest on your nervous system. It dehydrates and wrecks your. It's hard on the brain. You can die from the withdrawals. It's a really crude substance, and for some reason we've picked that one to make socially acceptable. But, I mean, people do stuff every day that they know puts them in danger. The whole thing about life is risk versus benefit. You can't fly in an airplane or drive a car without assuming some risk. I mean, this was a big, over the last 3 years, this was a big kind of debate about how do people want to live their life? How did safety get so far up our list of priorities? In this country, I look around and just the signage alone, it confuses me. I get baffled, like, be aware, a sign about something important coming up in 15 minutes, or, it's over the top with the labeling and it's like, why are we so, it's like somehow we got obsessed with quantity of life and quality of life just got thrown out the window.
Yeah. Yeah.
Weird. I've never understood it.
Yeah, well said. I get what they're. I think they're probably again looking at, like, are you drinking and driving? Are you, going out walking down a dark alley to find and consume your substance of choice? Like, they're talking about maybe more overt behaviors, but it is in fact way more subtle than that.
For sure.
And that point comes out as feeling dated.
Dated and a little silly in that
Mm-hmm.
we're still like reading literature from some physicians in the States. I can't, it's like I feel like I'm in some kind of a simulation that has gone crazier. And then that's not the only reason I feel like that. But when I read some of these publications, I'm like, they don't seem to grasp this. There seems to be this belief that every single drug has some kind of super intrinsic, it's like a death sentence just using morphine or something like
Mm-hmm.
that. And I never understood, like, these are supposed to be people who understand pharmacodynamics. They understand the way these drugs are processed in the body, especially if we're going to allow alcohol. We know alcohol is really kind of hard on your body, but like opium, I mean, these are things that we've been using for years and years and years. You could use till you're 90 years old. It's not going to kill you in that way. It's not like the drug itself is inherently dangerous. It
Mm-hmm.
has risks, and those risks are real. But it's this weird kind of this built-in assumption that every drug automatically impairs you, and every drug automatically causes damage,
Mm-hmm.
and sometimes irreparable damage. That's the idea. It's nothing could be further from the truth.
Yeah, and again, if there's a perceived if the perceived risk is more immediate and short term, our society's comfort level with it goes way down. And
That's right.
if the
Yeah.
risks are really long term or like way off in the distance, we seem to be more comfortable with it.
Yeah, like nuclear war on the other side of the Atlantic. That's fine. That's fine. But damn it, you better put that cocaine down or I'm going to call the police.
Yeah.
I don't know. Continuing to use, even when you know you have a physical or psychological problem that could have been caused or made worse by the substance.
Well, again, this is kind of a redundant one, I think. Is it going back to the work, social, interpersonal implications?
Well, the fact that they mentioned psychological could be alluding to, it makes me think about like young people using heavy doses of cannabis and being susceptible to schizophrenia, stuff like that. I mean,
yeah,
that's a real, we know now that if you're using cannabis and you're under the age of 25, it, I think, triples your chance of schizophrenia coming out. But you have to have the genes for that to happen, and that it's likely that you would have had schizophrenic symptoms anyway. But the cannabis, I think other psychogens too, but we know for sure cannabis makes it more likely to come out sooner.
Mm-hmm.
So, or other psychological problems, I guess, like maybe if you were maybe using a drug like methamphetamines and you know that your grip on reality is you're not sleeping properly, you've already had a psychotic break, but you're continuing to use. I mean, to me, this is a question that is, it's kind of like, well, if you're at that point, then why are we doing this silly little questionnaire? You know, I don't know.
Yeah, and I think thinking back to myself, I think I'm not sure if I did make this argument, but I could have made the argument that, well, I was depressed and anxious before. I was depressed and anxious anyway.
Mm-hmm.
The experience I was having with repeated and recurrent trauma in the workplace, that had a psychological impact that I was trying to sort of self-medicate for and cope with.
Right.
Did the substance, what did that do to my mood? It short-term elevated it. There were long-term, I think longer-term effects on my mood and on my psychology. But again, that's related to isolation. Okay. I was isolating anyway, probably. And we know that things like trauma have that same effect.
Right.
So,
well, you could even replace, instead of saying continuing to use, you could say, in your case, continuing to go to work, even when you know you have a physical or psychological problem that could have been made worse by going to work.
Yeah.
Right?
Wow.
You were using a substance to mitigate. It's not that the substance was the problem. The substance was the solution to the problem that already existed that needed to be taken care of in the first place.
Yeah.
You know?
And it doesn't. The gains on that are short term, shift to shift.
Yeah. And
hour to hour.
It's not a sustainable long-term gain or a game, but it is an excellent short-term strategy. There's no question about it.
Right. But
Yeah.
I mean, I know that going back to our discussions of the machine, that there is a real hesitation to accept that, just what you said.
Oh,
that it is
sure.
far, not only easier, but far more desirable, there's far less accountability if all of the associated behaviors or psychological impacts are placed on the substance.
Oh,
and less on the environment. Yeah.
Yeah. Yeah. The bigger machine needs that to run. If we start talking about the bigger machine, then that's a societal situation that's overwhelming, right?
Yeah.
These are cultural problems that are causing us to be in this situation, coupled with stupidity and just a bunch of other weird factors that are difficult to understand, but economics, I guess. But yeah, nevertheless, you're right. It's easier to blame the substance.
Yeah, but we pick and choose, and the machine and the systems pick and choose, and the individual who goes home to their 2 glasses of wine every night, or hits the drive-through for some saturated fats and sugar at the end of their shift, because their workplace is so psychologically intolerable. And the system would look at them and say, that's not on us. Mm-hmm. That's not on us.
Yeah, you're just making poor decisions, buddy.
You're just making poor decisions, exactly.
Yeah. Number 10, needing more of the substance to get the effect you want, aka tolerance.
If we're talking about someone with a prescription or with chronic pain or an acute health issue that's requiring something, there are a number of factors that could play into that.
Yes.
Metabolic factors, biological factors. We could talk for an hour about that.
This is a terrible one for accidentally capturing chronic pain patients in this net.
Yeah.
I mean, what are they supposed to do? This is the way the system works. I mean, we're designed in such a way, we're trying to do better, but I mean, if you have a condition that is, where you're in moderate to severe pain all the time, those drugs are not going to do the same thing forever. You're going to have to take more, and sometimes you're going to have to add adjunct, like even ketamine, to get more sensitivity out of some receptors, and that's just reality. So that's kind of not something that they have any control over. For people who are using drugs recreationally, sure, understandable question. I think all it does is speak to your the repetition in which you're using your drug of choice.
Mm-hmm. Yeah, for sure.
And then further along that line, we have number 11, development of withdrawal symptoms, which can be relieved by taking more of the substance. So, yeah, I mean, it's just kind of another way of saying that you're using it quite often.
Yeah, that's right.
Probably, I mean, what would you say with opiates? I'd say you were riding the line there for quite a while. It was quite impressive. I don't think I could have done what you did there, but if you're using maybe 4 days a week, you're going to get something, right? Your off days are going to be shitty at least.
Yeah. And I think we've talked about that. I don't know how much I recognized it or how much I just sort of put it off on how I was feeling in general. I think that can be masked by other substances, like, use of marijuana or alcohol to manage withdrawal symptoms, even unknowingly.
Sure. Yeah, absolutely. Yeah, you can do that. Yeah, some people are more sensitive to not chronic, but say subchronic withdrawal. Some people can tolerate that quite easily. Other people are I'm very sensitive to it. I start using something like even Percocet, and I do that for like a week. I'm looking at some trouble there afterwards. I'm going to have a few days where I feel like shit, for sure. So that's the 11 questions that they use. So afterwards, they go on to give you a mild, moderate, or severe which are, they're just words. But basically, the mild is if you said yes to 2 or 3, and moderate is 4 or 5 symptoms, and then severe is 6 or more symptoms. So, yeah. How many of you at home have a substance use disorder that you were unaware of before this episode?
And in the case of those who are, maybe early on in the machine or, awaiting their IME, it really doesn't matter.
No, it really doesn't matter.
To the impact of what's about to happen to you professionally and going through treatment and all that other stuff. Mm-hmm. It's kind of arbitrary.
Yeah, if you are awaiting an IME and you haven't got there yet, and you haven't divulged anything, and you want me to tell you exactly how to get out of it before it starts, I am willing to do that. And there is a way, but you will be doing quite a bit of lying. So just be prepared for that.
I remember that's a good point. Like I remember, I don't recall that I knew that those questions were coming, but I know, and I'm sure other people who are listening have had that experience where they think, how honestly do I answer this question? And I don't know. I don't have an answer to that one way or another. I did decide to be honest with them, mm-hmm. and to be honest in the questions. And some of them were vague, and some of them I was able to say I don't know. Mm-hmm. Particularly the question about like impact on work or school or something like that. Like I think I said I don't know how it actually impacted my work, and here's why. The bar is so low that you're probably going, from capture to the IME, you are probably, your path is laid out.
You're going on the SS Homewood, whether you like it or not.
That sounds pessimistic, Nathan.
Well, it's not all bad. It's just the better you understand the circumstances of what's happening to you, the more information you have before you enter the mouth of the machine, mm-hmm. the better. And it's going to be much less confusing, expensive, and time consuming, because it's really weird. And it's if you don't have some help with it, you can get yourself really twisted up in there. So,
yeah. And I think like we all in our heart of hearts know whether, the answer to that question, how is this working for you? We know that one way or another.
Sure.
And we can answer that honestly to ourselves, aside and apart from the 11 questions in the DSM.
Well, this is the other thing. If you're going to be honest, there has to be a decision made before you even show up in this to be questioned.
Yeah.
If you're going to be honest with yourself and whatever physician is issuing this test, then is there a point really to it at all?
Mm-hmm.
Because if you have a problem, you would say, doctor, I am having a problem, and here is the ways that it's affecting my life. I can't seem to stop doing this behavior. It seems compulsive. I don't know what happened or how I got to this point, but I do know that I need help and I can't do it by myself. So that's it. Mm-hmm. There's a lot of fleshing out that can be done after that to find out what avenue of help is going to be most effective. But for the first part of it, do you need help, or are you just a person who is using drugs recreationally and you're fine?
Yeah.
That needs to be a possibility. And with this criteria, the DSM-5's criteria for diagnosing substance use disorder, it's almost impossible not to qualify. I don't know what kind of a Ned Flanders type individual would be able to answer honestly these 11 questions and not get diagnosed.
Mm-hmm.
So to me, that net is just way too big. That's the first problem that I see with it.
Yeah.
Would you agree with that so far?
Oh yeah, certainly.
Okay. The other thing that I take issue with is that the way it's set up it is a kind of a top down, it's a patriarchal kind of, I'm diagnosing you and you don't know what you're doing type of thing, where it takes personal freedom and autonomy. It takes whatever insight, it takes your right to do what you want with your own nervous system completely off the table.
Mm-hmm.
So that's a problem that is built into the structure of it. I understand why, but it's not helping.
Yeah.
Further to that is the criteria that are discussed are exacerbated by the legal system and our current drug policies. So if we were in a world where we were grown-ups, then a lot of these things you wouldn't have to answer yes, because the question would be moot.
Yeah.
You know, why am I spending so much time to get my heroin? Well, because I don't want to do 10 years in prison. That's why.
Right.
Okay. You know, it's and if you could just access pure diacetyl morphine in injectable form for whatever dollars, and I mean, how on earth is that? If that isn't indeed a medical issue, then why don't we just solve it medically? You know, I don't know. It's a strange one.
There's an inherent sort of classism that's embedded in that, like
for sure
the very wealthy person who can pick up a phone and have their cocaine delivered to their doorstep is spending very little time.
Yes. And this is becoming more of a thing with the toxic drug supply too. What I'm noticing is there is now, I mean, it's always kind of been like this, where you can get better drugs if you know the right people. They're higher up the chain. But now it's like, if you don't know the right people, you could die.
Mm-hmm.
So it's a little more extreme out there if you want to do recreational drugs. You're not going to be rolling into town and just wandering around the bar asking if anybody knows where they can get some cocaine. Like you can end up overdosing on fentanyl.
Yeah.
And then maybe the biggest problem with this is that it would be impossible not to diagnose somebody with a chronic pain condition with a substance use disorder using this criteria.
Yeah.
And what's happening to chronic pain patients right now in North America is criminal. People are dying because of deprescribing, because of this idea that it's the drug that's doing this, right? Not the drug policies.
Yeah.
And I'm not blaming the physicians, because just like when this whole thing started, we're paying tax dollars and trying to choose leaders to represent entities or bodies of government that are tasked with regulating the way these drugs are prescribed and regulating the way they are used, and it's supposed to be in a way that helps people, not kills people.
Mm-hmm.
So I don't know how we got to this point, where Purdue was allowed to do what Purdue did. I mean, I understand the economics of it and the backroom deals and the bullshit and all that kind of stuff. But why the knee-jerk pendulum swing in the other direction, knowing that, we know what it takes to taper somebody off these things. We're doing it way too fast.
Mm-hmm.
They can't get the drugs. They go outside, they get street drugs, and they die. Well, I don't know, man. The first rule of medicine. What's the first rule of medicine?
Do no harm.
Yeah. Death is pretty harmful.
There was a big push a couple of years ago, and I know that there are countries who have done this more aggressively, to get opiates out of emergency departments. That the goal was going to be that you would not receive an opiate if you came into an ER, even if it was like with an acute pain condition, cholecystitis or a broken leg. You were going to get probably an anti-inflammatory, an NSAID, and extra strength Tylenol or some other adjunct. And given what we're talking about, first of all, in Canada and in our province, that hasn't been what I've seen. That opiates have been very, very widely and freely used in the emergency departments for the last number of years.
It's still an
And
still an emerge. It's good. Yeah.
yeah, but to take that away for the chronic pain patient or the patient with an acute pain condition who maybe had a prescription and they've run out or they've had to increase their dose to manage, you have to think that you have pushed some people out to the streets, that you have caused accidental deaths.
People have died because of these policies. There's no question.
Yeah.
It's especially bad in the States. I mean, Maya talked about it quite a bit. And we're a funny species. We really are.
Yeah. And I guess I'm saying, like, are we, if we're picking our battles, have we picked the wrong battle or picked to fight the wrong battle the wrong way?
Well, we don't seem to discern between what we should be battling and what we should not be battling very well.
Right.
Like how did chronic pain even get rolled up in this? Like, why are these poor people even being harassed? You know, is the idea like, okay, so the regulators shit the bed in the States, especially with these pill mills that got set up and the OxyContin highway and blah, 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 blah. What did a chronic pain patient have to do with that? That was some crooked people who seduced some physicians right out of school, you know, offering them a Lamborghini and $1 million paycheck to just prescribe pills. And then the regulators didn't do anything about it.
Mm-hmm.
So if you're not paying attention to any of that stuff, what's the difference between that and a cartel? You know, there's very little difference. So you're still not doing the job. The job is to regulate.
Mm-hmm.
That's the whole thing. Like, not make it so that nobody can get it, not make it so that everybody can, like a child can roll up on a tricycle and get an injection of fentanyl. There's something in between, and it's called pragmatic regulation of the drug supply.
Yeah.
You know, maybe we'll get there. I don't know, man. I don't know.
And there's the other side of it that gets spoken of very, very rarely is how patients with pain and chronic pain are treated in the healthcare setting, and how someone who is deemed a frequent flyer a regular, how those people are treated. And if you want to see stigma, like stigma that is like a muscular stigma, stigma that is well practiced, it's there. And like, and it comes by way of like microaggressions from staff. It comes by way of sometimes more overt rudeness and denial of treatment by staff, which is then violating a practice standard and a code of ethics as well.
No, I know exactly what you're talking about. I see with this deprescribing, I'll see a patient. Back when I was active pharmacist, I'd see people come in with topical creams to replace their, they were taking like OxyContin oral, and the doctors made it seem like this is going to be the same thing to get them out of their office, right? And I know that's not going to touch their fucking pain.
Yeah.
And now you want me to now I'm supposed to charge this person way more than those compounds are expensive, so I'm going to charge them. It's not covered. So the person doesn't have any money. They can't work. It's just, the whole thing is fucked. Like, what? Anyway,
it is so fucked, Nathan. There is an electronic medical record for each individual in our country that can be edited. That every healthcare professional's notes are uploaded onto and can be accessed in future visits, and it can be edited in such a way that a flag comes up when John Doe enters an emergency department that says drug seeker.
Yeah, because it happens in pharmacy too. Yeah.
For sure, and that may be because maybe they've been in 20 times in the last month, and that could be for a variety of reasons, misprescribing or underprescribing. It could also be a nurse who's frustrated, and there's something about their interpersonal dynamic that is off, or that rubs that nurse the wrong way, or that nurse has lost their patience because they are human and overworked. And they say, oh, John Doe is a drug seeker. I'm going to put that on the file. And then the next time he comes in, what's the first thing that the next individual sees before they have even had a conversation is this person's a drug seeker.
Yeah, it's a really shitty thing to do.
Yeah.
I really wish, and it's not that I don't understand, man. Believe me, I understand what you're talking about.
Yep.
I've had people, you know, they are drug seeking. They're looking for drugs. They don't even have a problem. They want their drugs and they're ready to hop over the counter. That type of person is annoying. I get that. But that doesn't mean that you can take out the brush and just start painting everybody who is in pain with the same. It's no, you have to be able to reset and discern. Yeah. So that's the end of my, I think that's the end of my general concerns. And then we do have some suggestions that are, just us as commentators. We put our heads together and came up with a few things where we think some questions that might be more useful or maybe more up to date, so people can do with them what they will, and maybe it's more food for thought, to generate a kind of a inner dialogue and an honesty with yourself about where you're at. And also, we've got a question in there at the end that hopefully is kind of it's a safeguard against chronic pain patients. So they could answer yes to the first 5, but if they answer no to the 6, then no problem. So, do you have that? You've got that list, eh?
I do. Yeah.
Okay. What do you got for the first one of our suggestions?
The first one I have here is, are you physically dependent on a substance? In other words, would you suffer from withdrawal symptoms or feel sick or anxious if you suddenly stopped taking your drug of choice?
The same as the DSM-5 in that it's going to give you some information and get the person to think about how often they're using that substance and if there's going to be any repercussions. If you're locked into a substance, then that's just something that you need to be aware of. And I like my grandpa would be a good example of a guy who he knew that he drank a certain number of beer every day, and he knew if he didn't drink those beer, he would have withdrawal symptoms and he would have anxiety and stuff like that. But he just never didn't drink those beer, and he had himself a great life right up until the time he died, and everything was fine. But that's a decision that he made because he knew that was part of the deal. So it's, if you're in a situation where you're going to be using a drug chronically, just be aware that physical dependence is a real thing.
You formulated that question, Nathan. That your language is much more empowering to the individual, and it's keeping that individual sort of in the driver's seat, I think.
Exactly. It's an opportunity to just check and make sure that person is aware of the risks that they're taking. Right?
Yeah, there's more dialogue embedded in the question.
Mm-hmm.
So number 2, do you have concerns about your health related to your drug use?
Yeah, health or well-being. And I actually I thought about the order of these, and I did change them around a little bit. I've got that one at number 1 now, because that should be the opening dialogue. I mean,
sure.
What are you doing here? Are you it's a teenager and their parents sent them in to see the addiction specialist. Oh, what are you concerned about your health or well-being? What's going on? Oh, no, not really. I'm doing such and such on the weekends, and I know I know there's some bad drugs out there or whatever, but I test my drugs. I don't use hard drugs often, whatever it might be. Or, yeah, actually, I am concerned. I've been, drinking too much, and I've been drinking too often. I'm worried about my liver. I'm starting to feel depressed. It's actually affecting my sleep. There's a lot of information that could be kind of taken out of that if you fashion it in a way where people can talk about their well-being and how that drug is affecting their health.
Yeah, exactly.
And it's also an opportunity to educate people about the real risks of drug use, the inherent risks, because many people believe that, if they do a line of coke, they're going to have a heart attack. That kind of, because of all the propaganda that we've had pushed at us.
Yeah. You read the next one, Nathan, because I think the order is relevant and important. So,
okay. Is drug use making it difficult to achieve your goals?
Yeah. So going back to the DSM list, this version, if your job's not important to you, if school's not important to you, then it's not going to matter anyway how you answer the question. But looking at whatever it may be, maybe it's video games, or maybe it's your quilter's bee, whatever that may be, what is of value to you?
Yeah. What is of value? And then is the thing getting in the way of that?
Yeah.
A good example would be me when I quit using cannabis. I was a heavy cannabis user when I was a teenager, but I was also a martial artist. And I got to a point where I realized that my cannabis use was affecting my ability to get to a certain level. So I stopped using cannabis. That's just, I mean, that's the decision that went on in my mind, and it just was getting in the way of my goals. That's it. Mm-hmm. So
your goals, not the societally normal goals.
That's
goals.
Right. Yeah. Not Dr. Smith's goals, my goals.
Yeah.
So number 3, is drug use causing you to self-isolate or making it harder to connect with people? I think this is important because so much of our mental health is determined by our ability to connect with each other. We're social animals. Self-isolation is, well, we know now that loneliness can kill you. So I think you need to be really careful with drugs that provide, especially those ones like opiates that give you the oxytocin with the dopamine. So it replaces that, it's like you're getting a hug, right? And it makes people obsolete. So you really got to be careful if you're using drugs like that on a consistent basis. Make sure you're checking in with people, find a way to connect, I think there's an argument to be made there that there's not many people out there who could use opiates in a real heavy way and still form good connections. But I mean, everybody's different. So I think that would be true for probably both of us. It would cause a problem. Sure. But maybe not other people. So number 4, have you tried to cut back on your drug of choice but found it difficult or impossible? And I think that is, again, that's very close to the DSM-5, but it's important that point is looked at closely, because the very nature of addictive behavior is that compulsion to use, even when you feel like maybe you're aware of some of the things that it is getting in the way of your goals. You're worried about your health. These other things are going on, but you're still continuing to do it, and you're starting to scratch your head and wonder why. That's a pretty good sign that you might be in trouble, right?
Yes. Yeah, exactly.
So I put number 5, the one that you mentioned, just after that, to kind of reiterate about, it's a way of addressing chronic use and what to expect with chronic use.
Yeah.
And then my final question, which is kind of the question that, the one question to rule them all type of question is, do you feel that the way that you use drugs is leading to more negative than positive experiences in your life? So if you notice, a chronic pain user of like an opiate would possibly answer yes to question 1 through 5. It's possible they could answer yes to every single one of those questions. But if their drug was still giving them a quality of life that exceeded not having that drug in their system, then they would answer no to question 6, and thus all is well.
Yeah. Within the Smart Recovery program, the cost benefit analysis is one of their foundational tools that early on in Smart Recovery meetings, you'll do a cost benefit and discern whether the benefits are long-term or short-term, and whether the costs are long-term or short-term. And I mean, that one requires a really, really, really honest look at yourself and at your behaviors and everything that's going on in your life, and all of the ways that you think that the substance is helping you navigate your life. And is it helping you navigate the short-term or the long-term?
Yes. And I think that is, there's some insight that needs to be, you need to be at a certain level of capacity to have that insight, and then having people close to you who can help you with that. Other people, peers. This is where peers come in really handy.
Yeah.
They understand what you're going through, and they will likely have had this similar kind of insight experience.
Yeah.
So, but I mean, yeah, ultimately, if you're using drugs either properly for a medical problem or recreationally, and you're not out of control, then what's the problem? Right? There needs to be some room for that.
And at least room for the discussion, room for looking at it and getting super honest about it. Yeah.
Mm-hmm. Yeah. Yeah. So I expect that we'll be getting a call from whoever writes the DSM-5, and they will immediately accept these new parameters as their diagnostic criteria. But fun exercise anyways.
It was, yeah. And it shone more light on the DSM questions than I thought it would, and looking at really what's problematic about it.
Mm.
And like you said, it's a very, very wide net.
Yeah, it's a little bit preposterous when you look at it closely.
Yeah.
But yeah, that's all we got for this one, folks. Just a reminder, existing patrons, you've probably got an email at this point talking about how you are now on our list of there's a loyalty program. So we're going to send you a gift every 3 months that continues to get better and better. And then we have some new sign up gifts that are now in production. So just a little heads up there for people who might be thinking they want to become a patron, or anyone who's wondering why they're getting an email asking for their shipping address. It's because we're going to send you stuff. And then, next we have a psychologist coming up from Boston who's got a new book out, and we're going to discuss that with her. And I think that's going to be pretty fun.
Yeah, we're going to talk about codependency. That's a subject when, in looking at her book and our sort of preliminary emails with her, I kind of wondered, why haven't we talked about this yet? So
yeah,
so it'll be cool.
It's interesting. It's going to be a fun conversation, I think. So that should be soon. She'll be here just in a few days. So yeah. And other than that, do we have anything else we need to announce, Corey? Everything's going good.
I think so. Yeah. I mean, more merch to come, whether you're a patron or not. But otherwise, yeah, feel free to explore our Patreon page and sign up, because there's a pretty small minimum there. So
yeah, absolutely. And our store is it's all ready to go. We're filling it up with stuff, and we have a hopefully we're going to look at having a grand opening, probably May long weekend, something like that. That's what we're aiming for. So we'll have all sorts of interesting items that might interest you in there. Yeah. So stay tuned.
Yeah.
All right, everybody. We'll see you next time.